Well, okay. Why don't we get started? Welcome, everybody, to our cardiothoracic surgery professional community webinar. Today, we're focusing on perioperative optimization in heart and lung transplantation. My name is Dave Nagpal. I'm a cardiac surgeon and intensivist in London, Ontario, Canada. I'm the surgical director of a mechanical circulatory support and the co-director for our multi-organ transplant program. We've got three fantastic talks today, focusing on different aspects of peri-op optimization. The first talk we will do comes from Dr. Valan Jivanandam. He's the Cynthia Chow Professor of Surgery, Director of the Heart and Vascular Center, and Chief of the Section of Cardiac Surgery at the University of Chicago Medical Center in Chicago. We have a video presentation for him today because he was unable to give it live. Hopefully he'll be able to join us. He'll be talking to us about blood conservation strategies in heart transplant and LVAD implantation, a single center experience with more than 100 Jehovah's Witness patients. And just before we start the video, can I remind everybody to mute your microphones if you're not speaking? Feel free to stay on camera. But if you mute your microphone, that would be much appreciated. To start off, we'll have any questions put in the chat room, and that'll allow us to organize our questions better. And that'll be followed at the end of the three talks by discussion.
I'd like to thank the opportunity given by the ISHLT and Dr. Nagpal for presenting our experience with bloodless advanced heart failure surgery in many patients. So I have no disclosures, and my talk today is going to be focused on patients who refuse blood products even if it leads to death. So we're not talking about blood management where blood is only given during an emergency, but these patients actually completely refuse blood products no matter what the consequences. So before one embarks on a program like this, you need to self-reflect, because you need to have the ability to respect beliefs of people who refuse blood, especially when it's not your own. And you also need to have a team that is psychologically stable and physiologically aligned to be able to give care to these patients where their beliefs may not be completely equivalent. So bloodless therapy removes a safety net. Now, are you ready for this? In other words, how about your SRTR data, STS data, US News and World Ranking, and institutional acceptance? Now, why do you want to do this bloodless surgery? What we have found is that it decreases blood utilization and improves outcomes across all patients, and it does provide access to a very underserved population of patients who have these beliefs. How is it done? Well, transfusions have consequences, but are critical as a safety net. And if you have to operate on people without that safety net, it feels like Philippe Petit walking across the World Trade Center, which he did in the 80s. So in terms of treatment of bleeding, there's actually not successful, as the horse is out of the barn. The real secret is prevention. And you prevent bleeding by having good patient selection, preoperative preparation, and surgical techniques. And of course, you have to have good postoperative management. In terms of selection challenges, reoperation sternotomies, of course, are a challenge depending on where the structures are underneath the sternum. But particular situations where we may actually not offer this therapy are Fontans with single ventricles. Most of these patients have a lot of right-sided heart failure, liver dysfunction, and multiple operations. Or LVAD explants or transplants. This again is a very difficult procedure to do without absolutely any blood products. We are selective in patients who have very high PRAs, hepatic dysfunction. We do not offer heart kidney transplants simultaneously, but now with safety net kidneys, we have started to offer a heart transplant and a delayed bloodless kidney transplant if needed. In terms of bridging strategies for these patients, whether they're looking for an LVAD or a transplant, We offer ECMO, subclavian intra-aortic balloon pumps or Impella 5.5s. And in terms of advanced heart failure therapies, we will offer them a durable LVAD, but these are purely as destination with no expectation of future transplant, or we offer them transplantation. From preoperative preparation viewpoint, we stop anything that could increase bleeding, such as warfarin, clopidogrel, aspirin, supplements. We build up their hemoglobin. This is a goal of 13 to 15, but honestly, most patients come in at about 11 or less. We give them high-dose Epigen, upwards of $20,000 sub-Q daily. We also give them doses of Epigen immediately intra-op because, as you can see on the right, it's associated with decrease in kidney injury and decrease in generalized inflammation. We also make sure that their iron stores are adequate. Bioavailability is always a concern if given orally, so if they're in the hospital, we end up giving them IV iron. Prior to their procedure, we'll give them at least 3 or 4 doses of IV vitamin K, even if they have not been on Coumadin. And we hold their diuretics, and this is important because as you hold their diuretics, their blood volume comes up, and it allows for an easier pump run. So when you take these patients to the operating room, they never really will be fully optimized. In terms of the surgery itself, we talk about meticulous surgical technique. We accomplish that by having a very limited team. There's only one surgeon who actually does the surgery. We have PAs who are particularly experienced. We have perfusionists, nursing, anesthesia. And again, you have to be preventive. You have to know where your patients bleed from and prophylax against them bleeding from these spots. So we know from these patients that the sternum is the primary source of bleeding. And so when we do our sternotomy, we actually take our time. So the real trick here is patience. So we take our time, we do the sternum several times, often upwards of 3 times before we put in Surgicel strips, we put in a towel. The sternum is the primary source of bleeding, and if you can stop this bleeding even before it starts, before the surgery, then you actually have a good head start. After surgery, we oppose the sternum with titanium plates. This minimizes the amount of wires you have to go through the sternum with, and this really has shown to us to at least minimize pain and minimize bleeding. Once the sternum is open, and if somebody is a re-op, the key here on these adhesions is you have to be very, very slow and meticulous, and every small bleeder needs to be electrocauterized because they add up. So it starts off at the skin. We avoid any type of blunt dissection. And as you can see here, these type of adhesions, although a little vascular inflammatory, would be very easy to just take your hand and just swipe and do blunt dissection, but that also will lead to a tremendous amount of bleeding. So this is a combination of the surgeon and the assistant not going wild with blunt dissection and taking everything down with cautery. Now, despite this, at the end, if we do have bleeding from any type of raw surface, we'll use the Aquamantis device. As I tell my fellows, the number one problem is not a coagulopathy, it's most commonly suture deficiencies. And this is where the surgeon needs to be able to predict where the problems are going to occur by going into your own database and figuring out where is it very difficult to repair, how often does it occur, and if it's difficult to repair, it occurs reasonably frequently, you better put double stitches in there in the beginning so you prevent bleeding. And for instance, on a transplant, we know that on the left side of the left atrial cuff, whether it's a total or a bicable, that area requires lifting up the heart. It's often hard to see. When you lift up the heart, it could stop and then bleeds later. And so that's an area that we focus on doing double layer of anastomosis. And the PA, especially the posterior PA, can bleed as well. So for those patients, this is our left atrial anastomosis, as you can see, and we always reinforce it with these large pledgeted sutures. And for our PA, we fold the PA on itself and then do the anastomosis to a double folded PA to decrease bleeding and to give better structures to close with. You can see here, if possible, we also fold the donor PA on itself. And at the end of this operation, this is a patient, we expect complete hemostasis before protamine and before any of before protamine and before giving the blood that we saved during surgery. This is a LVAD, and during LVAD implantation, I often do the core first so I can see the mitral valve and do an Alfieri stitch. And when you do that, you often have bleeding from the apex. So what we do is we use this 20 cc syringe, we create a stopper, we take the black plunger and we actually create a mechanism where we minimize bleeding. Before we actually do the core, we turn the sucker on full and empty out the LV. And as you can see here, we're able to see inside the LV without any blood. And in a Jehovah's Witness patient, all you need is 1 or 2 contractions of the heart that's full with blood, and you'll easily use 100 to 200 cc's of blood. After we do the anastomosis, we'll then go ahead and put it in our VAD. And once we put in the VAD, we actually will infuse volume into the patient, pressurize the LV, and wait for 5 minutes and see if there's any bleeding in this apex. Because if there's any bleeding in this apex for a Jehovah's Witness patient, it's going to make for a very, very long day. So again, these cases do take a longer period of time, and you do have to be very, very patient. Now for the aortic anastomosis, we will use a Teflon gasket. We make one up here, and we go ahead and use interrupted sutures around the anastomosis, and then do an over and over anastomosis, and we ensure complete hemostasis before we take off the clamp, as you can see there. And you can see here, this is one of our LVAD patients before we close, and again, we demand perfect hemostasis before it's closed. Other ways to decrease blood loss is to decrease the number of sponges and pads. And what we do for our transplants and LVADs is that we only have 1 4x4 and 1 lap pad. And the nurses basically reuse them over and over again by wringing them out, and then we put them on a cell saver. And at the end of the operation, all you have is 2 pieces of laps. Now, the nurses have to do a lot more work. In the beginning, they were upset at doing this. On the other hand, at the end, you don't have to worry about a lap count because you only use 2 pieces of gauze, and so lap counts are very, very easy. The other thing that we follow is we warm the patient. We warm the patient to 37 degrees, and we keep them there for 10 minutes to make sure that they don't get cool by the time they get to the ICU. Anesthesia is critically important for these patients. We minimize the volume on induction. We use a special bypass machine with the ultra-low priming volume. We do drain heparinized blood from the patient. You can see here, it's a bypass circuit off the venous reservoir. And this blood has preserved platelets and coagulation proteins. We drain about 600 to 1.2 liters off in a heart failure patient. And then we reinfuse after cardiopulmonary bypass protamine, and there is no surgical bleeding. We also use cell saver. Postoperative management issues, renal dysfunction, all these patients we put on either renal dopamine or phenoldipan till the creatinine crests. We use large cannulas to maintain high bypass flows with the DO2s of greater than 350. We avoid pressors on these patients. We minimize their lab checks. We use albumin for volume. We actually keep these patients intubated until cardiac function and mental status is normalized. Last thing you want is somebody who's aspirating and then needs ECMO. We start all patients on 20,000 units of Epigen daily with iron, and we do accept low hemoglobins. Now, this is an example of a patient that we did recently. Patient 50-year-old female, a Jehovah's Witness, transferred from North Carolina, long-standing heart failure. You can see she came to us on dobutamine and milrinone. with pretty not great hemodynamics, including severe RV dysfunction. We added a balloon pump and diuresis. It got a little bit better, but not significantly so. We added an Impella 5.5. Again, not great improvement, and we did decrease the hemoglobin because the hemolysis. She ended up needing an AVR, a combination of existing AI and Impella pump. We did a mitral valve repair, an Alfieri through transaortic. We did a tricuspid annuloplasty, HeartMate 3. She nadered at 6.5 with her hemoglobin. 12 days after her 6.5, she was 9.8. She was extubated on post-op day number 3, which is a little bit late for us. Her creatinine went to 3.1 and then crested and came down. She did have some VT, and she was discharged to rehab on post-op day number 18. So what are our results? So in terms of transplants, we've done 46 over the last 10 years, of which 15 were reoperation sternotomies, so about a third. And out of those 46, we have 41 who are surviving to date. And the average time here is about 4.6 years. We lost one patient due to aspiration ARDS, who was a situs inversus patient. We had one patient suicide. You can see the reasons for death there, and not necessarily because of refusal of blood products or bleeding, but for other reasons. We did 10 in 2023. We've done 8 so far this year, and I've done 71, including my experience at Temple over the last 30 years. In terms of LVADs, we did 38 over the last 8 years, less LVADs than transplant, because transplant is better than LVADs for Jehovah's Witness patients. Again, about a third reops. A lot of them got concomitant valve procedures. We try to make their tricuspid and their mitral valves perfect. 1 year survival, similar to non-JW patients. None of these patients had a re-op for bleeding. 1 had a delayed closure, and only 3 ever received any type of fractions, although we do get consent for fractions. 1 received PCC. The challenges here, they come from long distances. Getting them transported in shock is always an issue. Insurance is an issue. We do ask them to relocate to Chicago, but the biggest issue is late referrals. Most places don't think that advanced heart failure therapy can be given to bloodless patients, and so we get very late referrals. But the techniques, the management strategies, and the dedication we have to the bloodless patients has elevated our entire program, and so we do very well with the leapfrog safety grades. And according to the SRTR, we have the best survival, the shortest wait times. We've done the most triple organ transplants. We've done the most bloodless, and we have the highest percentage of minority patients that we do. So this has elevated our entire program. So in summary, with a dedicated and passionate team of bloodless coordinators, and here you see our team along with the Jehovah's Witness Hospital Liaison Committee members from Chicago here. A combination of a team and meticulous surgical care where you accept challenges, you do complete procedures like multiple valves on a VAD, you think about the prevention and anticipate the future, but most importantly, you have to be honest. If you can't do the procedure or don't want to, please get them referred early and not late. But with all that, a lot of preparation, dedication, and good fortune, the most complex cardiac surgical patients with advanced heart failure can be done in all patients who refuse blood products with excellent results. Thank you very much.
Next, we've got Dr. Gabriel Luer. He's an associate professor of surgery, the George P. Moon Endowed Chair in Surgery Co-Chief in Adult Cardiac Surgery, and the surgical director for the lung transplant program. Gabriel, we're very happy to have you present today on the threshold for temporary mechanical circulatory support in heart and lung transplantation. Not too early, not too late. Gabriel, thank you very much.
Dave, thank you so much. Can you hear me okay?
Very well.
Okay, great. It's a real privilege, obviously, to be here with this group talking about this topic. A lot of it is is not necessarily new to everybody, but clearly the field has been evolving towards more complexity, more use of MCS. And so there's a lot of questions about when we use them, what types we use them. This is a little bit of a hefty topic because it does involve heart and lung transplant and MCS. So I'll go through it as expeditiously as possible. Should be right at about 10 minutes or just a minute over, if that. By disclosures, I do consult and have some grants support from a couple of potentially relevant sponsors. By way of overview, we're going to talk about lung transplant first and look at how the intraoperative mode of support is handled, and as well as the management of PGD, which are the two most relevant areas right now that are front and center in many of our programs. LVAD, we'll talk a bit about the effects of support, and obviously you more often than not need some support for LVAD, but we'll discuss at least the implications of that and temporary RVAD support afterwards. And then during the heart transplant, the threshold for using postoperative VA ECMO, I think intraoperatively, there's really not many other options other than cardiopulmonary bypass. So starting off with lung transplant, primary graft dysfunction is the biggest threat that we have to the allograft, and it tends to be very closely linked to innate immune factors, cytokines, inflammatory factors. The lung is particularly susceptible to a lot of this. We know this from heart surgery, from valves and coronary work. And so in a lung transplant, it's really no different. The landmark article published by Diamond, the Lung Transplant Outcomes Group, in 2013, showed that cardiopulmonary bypass was actually the biggest risk factor for primary graft dysfunction. So this has led us to kind of shift gears and move towards ECMO support whenever possible, understanding that there is certainly off-pump options as well. ECMO, unfortunately still also has a lot of cytokine and innate immune activation in it, as we're all aware of, though you don't have the volume reservoir, you don't need as much heparin for it, so that clearly a lot of advantages that we could have there. But we wanted to explore this question because there's a little bit of equipoise in how you can do this case. So we looked at our own data in a multi-center registry that several centers are a part of. We looked at 852 transplants. This was a per protocol analysis, so looking at what the patient ended up using, bypass or ECMO. Most of these were used prophylactically because over the last 5 years, people who were using ECMO were just using ECMO right away from the beginning, less so for rescue and kind of emergency situations. Did exclude single lungs and multi-organ transplants. Here, this gives you a sense of what the breakdown looks like worldwide right now, or at least as of the last 5 years. This could have been, this could likely be changing largely in favor of ECMO intraoperatively, even more so than off pump. But at the time of this study, 50% of the cases were done off pump, about 20 were cardiopulmonary bypass, and 30 were ECMO. You can see the split of primary graft dysfunction being the highest in the bypass group, second highest in the ECMO group, and lowest in the off-pump group. In the multivariate analysis, when we adjusted for all the potential confounders, especially patient-specific factors, intraoperative specific factors, still demonstrated that bypass had the highest odds ratio for primary graft dysfunction, followed by ECMO being a twofold increase in graft dysfunction. So we wanted to look to see if there are some biological mechanisms for that, looking at intraoperative biomarkers. And we looked at a slew of them, and what you can see here in green and red, green is the ECMO group and red is the bypass group. We see these peaks in multiple cytokine levels. So this one's looking at MIP1 beta, and these are all part of the innate immune response. So that initial response that we all have to any kind of antigen. You can see in 6 hours, it's almost immune silent in the off-pump group, but you see these peaks in both ECMO and bypass. Same thing with IL-1RA. Same thing with the IP10, although it did look like ECMO was a little bit less inflammatory, but overall there wasn't a major distinction between the two. And this shows the panel of other cytokines that we looked at, multiple of them being substantially elevated whenever any kind of circuit was used. So in general, I think that the take home in lung transplant is that we try to limit the support when feasible, but when it's not feasible, VA ECMO should be the go-to standard. Probably should limit the exposure whenever possible, because a lot of dissection can be done without the circuit. But in the threshold is going to vary substantially. I can tell you, even if I look and see that the exposure is poor, or that there's really any element that would make maybe it's done in the middle of the night, maybe there's an, you don't have the optimal assistant, whatever the case may be, we have a very low threshold for VA ECMO. But whether using it, across the board for all transplants, I think that's a question that's in evolution right now. And there's actually a randomized controlled trial currently underway to see if that would be the best way to do it. How about postoperative PGD? So here I'd fall back on the consensus statement from the AATS that was recently released, and I had the opportunity to be involved in reviewing it. But I think that it made a lot of sense for patients with severe pulmonary hypertension. They're at high risk of PGD afterwards. And so these patients may benefit from prophylactic VA ECMO, but the data is not conclusive on this. And we all know that VA ECMO comes at some cost also, bleeding, renal insufficiency, and other issues. So I don't think it's a smoking gun that everybody with pulmonary hypertension should be put on post-op VA ECMO. But if they are showing evidence of RV dysfunction, if you're concerned about them from the ability to perfuse and optimize in the initial perioperative hours, then it's very reasonable to have a low threshold for using VA ECMO for those. And the data from the Hanover, Germany group showed that there is some substantial LV remodeling that occurs, and they leave them on for actually 3 to 7 days afterwards to allow that to happen. But I think we have to study that further to see if that should be done for all PH patients. I think in PGD, purely respiratory, even though there are definitely hydrostatic components to it that where VA ECMO would conceivably be helpful, by and large, the majority of people are going to use VV ECMO, and they're very successful with that. And I think the threshold for using VV ECMO should be quite low. There's low morbidity, and usually we'll only need it for a day or two. So we tend to have a very low threshold for utilizing VV ECMO for PGD. Now, how about with LVAD? So we just recently presented this, our fellow Katie Nordic presented this in SIO in June. We hypothesized that bypass does increase systemic inflammation, pulmonary vascular resistance, and could lead to adverse clinical outcomes. So looked at the INTERMAX cohort of 20,000 patients and looked at 3 different tertiles, less than an hour, 1 to 2 hours, or greater than 2 hours of pump time. And what we found after adjusting for all the covariates that were available was that the pump time was independently associated with mortality, with acute renal insufficiency, and with stroke. And so to some degree, that's not unexpected, although I think that even in our practice, and we take a lot of liberty to expand the pump time whenever we need to. But I think that this has caused, a little bit of more caution towards deciding what additional procedures are absolutely mandatory. We saw some risk factors for who would have long pump times, and really no surprise, elevated INR, advanced age, elevated creatinine and CVP, but again, independently associated with mortality, renal risk, and stroke. So I think it's reasonable to adopt some strategies to limit the duration whenever reasonable. And also the time, if you're going to spend a lot of time for a particular valve, should be taken into consideration with the patient's comorbidities for risk stratifying them. Concomitant procedures are very helpful at times for helping your post-op processes, but we should consider them carefully in terms of how much longer it's going to expose us to the pump. So post-op RVADs, here in terms of timing for the RVAD, it kind of ends up being dealer's choice. Bottom line is that with an RVAD, you have worse long-term outcomes than you do without the RVAD. And this is data from Yoshinaka's group in Colombia. This is a very nice article in 2013 that touched on this. But what they did look at was putting the RVAD in right away in the OR versus delayed did not have a major difference in outcomes. And I would say that in our practice, we will utilize it upfront if we think that we're on too many pressors and it's going to facilitate the ICU management. I think that this study would suggest that there's equipoise in going ahead and doing that with a similar outcome. But we would definitely encourage using it when needed. Nowadays, with the Protect Duo and with the tandem support of the RV, if you made the wrong decision, it's not the end of the world. If in 2 or 3 days the RV starts sagging, you have some beautiful minimally invasive methods that you can use. We do try to tunnel them all so that we don't have to go back to the OR to remove the RVAD when possible. So finally, in terms of heart transplant, post-op VA ECMO support, this is a big deal with primary graft dysfunction. This was a wonderful expert review by the group at MGH that I found very insightful and really mirrors our practice. They allude to they basically support upfront or early consideration for VA ECMO use, as does this paper here from Columbia that looked at prompt versus conservative ECMO management. The prompt ECMO group seemed to have better survival than the conservative ECMO group, but you can see that it was not statistically significant. There was a beautiful systematic review very recently published in the Journal of Cardiac Failure that looked at multiple studies and multiple patients extracted from the studies. They did see a trend towards better outcomes when the VA ECMO was started early after heart transplant, meaning you don't even leave the OR without the ECMO running. Versus a delayed approach where you do it in the ICU if you need to later. So it did seem to favor this, but again, there was a lot of heterogeneity in the outcomes, and it did not reach full statistical significance, so they assigned it a low certainty recommendation. Interestingly, they also noticed that peripheral had better outcomes than central, with the caveat being that peripheral should always look at distal limb perfusion and make sure that you're optimizing that. They saw no difference for LV unloading. When they looked at how many deaths were prevented, 115 fewer deaths per 1,000 by hospital discharge in the early intraoperative cannulation group after heart transplant. But again, with the heterogeneity and the outcomes, they still assigned it a low certainty evidence score, and they did favor peripheral in this systematic review. So in conclusion, for lung transplant, intraop support should be used when needed, knowing that off pump is a very reasonable strategy also, but that threshold is going to be low and it may vary, and I have no trouble with going to VA ECMO when needed. For post-op PGD, VV is very ideal. Pulmonary hypertension, if you have RV dysfunction, consider VA ECMO early. LVAD, probably time matters, so it should be factored into the surgical plan. Post-op RV dysfunction, either early or delayed, depending on your impression of the case. There's not a lot of strong data one way or the other. And for heart transplant, post-op VA ECMO, early seems to be better than late, although there is not conclusive data on this either. And peripheral, interestingly, seems to be reasonable as long as you are factoring in distal limb perfusion, and perhaps that makes it easier to deal with post-operatively as well. So thank you so much, Dave, for inviting me to present, and be happy to take any questions afterwards.
Gabe, that was a fantastic talk and overview, and you're right, that was a ton of material that you very nicely condensed into the talk. Yeah. I've got 4 questions here, but I will, in the interest of getting the talks completed, we'll save them for our discussion. Thank you very much again.
Sure.
Next, we're very lucky to have Dr. Dominic Magna, Assistant Professor, Surgical Director of the Lung Transplant Program, and the Surgical Co-Director of the CSU at Cedars-Sinai. Today, Dom will be talking to us about improving pain management in thoracic transplantation, minimally invasive approaches, pharmacologic strategies, and future directions. Dom, looking forward to this. And just while that's getting loaded up, please, for our participants, start putting your questions into the chat room, and we'll make sure we get to those during the discussion.
Good afternoon. Thanks, everyone. Thanks, Dave, ISHLT, for letting me present. I'm Dominic Mania from Cedars-Sinai. I'm presenting on improving pain management in thoracic transplant, minimally invasive approaches, pharmacologic strategies, and future directions. I have no relevant disclosures to this talk. As many in this community know, lung transplants performed through big incisions, clamshells, large thoracotomies, sternotomies. While these incisions give us great exposure, they can be associated with significant postoperative pain, chest wall dysfunction, and wound complications. And I think as a lung transplant surgeon, quality of life is paramount to this procedure, not just longevity for the patient, but really quality of life. And adequate pain control is of vital importance to that quality of life postoperatively. And inadequate pain control can lead to impaired respiratory efforts, decreased cough, increased risk of reintubation, and pneumonia. Also, if you're not controlling pain postoperatively, these patients are going to have a worse surgical stress response postoperatively. You're going to see maybe more myocardial ischemia, more arrhythmias, maybe more elevations in their PVR. So all these things need to be taken into account, and pain needs to be taken seriously. And chronic pain, like I said, after lung transplant can impact one's quality of life, which I think is of utmost importance. Up to 10% of patients has been reported to have chronic pain post-transplant, and maybe up to half if you consider all patients who get thoracotomies for all sorts of procedures. And pain control not only is, it's not one-dimensional, it's multimodal, and it's a multidisciplinary effort. Unfortunately, we don't have a uniform consensus on how to manage pain, but there are factors that we can maybe adjust, and some of those maybe are surgical factors. The techniques we're using, the large maximally invasive incisions we're giving patients, and also don't forget about patient factors. A lot of these patients who are having lung transplants, they're coming in with depression, they have anxiety up front, and these factors play a role in pain after the operation. And sometimes the patients are ill-informed of what actually a lung transplant entails. So I think if you incorporate all these factors into them, we have some role to play here. What options do we have? Well, most, I would say, probably tend to use epidural anesthetics as part of the regional anesthetic approach. If failed attempts at epidural anesthesia are undertaken, then you can move to possibly a paravertebral block, and less commonly use our intrathecal blocks. If neuraxial blocking is not indicated, or it's contraindicated for whatever reason, you can use intercostal nerve blocks, erector spinae blocks. Catheters can be placed for these. And then the other alternative is a cryo nerve block, which some programs are now utilizing. Overall, though, the goal is maximal analgesia with the least side effects. So thoracic epidurals are used, all the time, been used for years in lung transplantation and thoracic surgery. And the benefits of it does allow for ease of the respiratory movements if you're numbing the area. And that's going to reduce the pulmonary complications. You're going to get decreases in pneumonias and atelectasis, and the stress response that I discussed, it's going to be reduced. But it's not without risk. There are some cases of epidural hematomas. There's systemic hypotension, which is a big factor after lung transplantation with all the hemodynamic and fluid shifts. And it can be associated with infection as well. But overall, the majority of these patients, these risks are exceedingly rare. But what about cryoablation? Some programs have moved towards using cryoablation. This is a study out of Penn, where they compared cryoablation to their standard protocol approach, which I have to say does not involve epidurals or paravertebral blocks or any sort of blocks of such. Just involves an IV oral opioid and analgesia with Tylenol. And if need be, they move to epidurals or further with blocks. But when they compared cryoablation to their standard approach, they saw lower pain scores when they used cryoablation and significant reductions in oral opioid medications. Now, the cryoablation takes about 16 to 20 minutes in most people's hands. You numb a couple levels lower. You try to get the chest tube sites, the site of the incision, and then the level above. It takes 2 minutes for each cryoablation. This is from the UCSF group, and they saw similar findings, but they compared cryoablation to epidural, and they found it safe with similar analgesic effects to the epidural. It may be less risk. It's not associated with hemodynamic compromise. It's a one-time application, and this may be potentially beneficial if we're talking about patients who need post-operative ECMO, anticoagulation, and sometimes patients do have coagulopathies after the procedure. So there's utility in these cases. Our approach at Cedars is multimodal. You know, if we're doing clamshells, standard thoracotomies, or a minimally invasive approach, we use epidurals pretty much on every patient. Unless we can't, if it's failed multiple times, we'll have a paravertebral placed. We'll use these up to 7 days with combinations of fentanyl and bupivacaine, but we adhere to strict coagulation guidelines according to the ASRA guidelines. So if it's contraindicated, we'll use intercostal or rectus spinae blocks. And once we have these blocks in, we transition off with oral narcotics, Tylenol, plus or minus the use of gabapentin. Aside from medications, we've transitioned our approach to a more minimally invasive way of approaching lung transplantation. And minimally invasive approaches have been described for some years now. They may offer faster recovery, reduced pain, a quicker return to normal respiration. However, if you look on the slide to the right, this is what some have considered minimally invasive. And in my opinion, this is not minimally invasive. This is just a sternal sparing bilateral thoracotomies. So when you're getting presentations on this, I don't think it's the same as a true minimally invasive approach. But there is little data that exists describing the impact of these minimally invasive techniques on early outcomes and analgesia use after lung transplant. Our technique at Cedars is we like to make small 6 to 8 centimeter incisions, either second, third, or fourth intercostal space, depending on the hilar anatomy in patients' pathology. The moderate use of a rib spreader, and then the dependence on these minimal access instruments. So people that are familiar with minimally invasive mitral surgery are very familiar how to use these instruments. These are the instruments we use to do the implant with not pushing devices as well to tie the sutures. This is an example of a patient. We mark out each spot. We start on the right side. We make the 6 to 8 centimeter incision. We chose the third intercostal space on this patient. Moderate use of that rib spreader with the Lexus wound retractor. We start with superior vein isolation. And all this is done, outside of the incision with the instrumentation. Then we staple ligate through this 9th intercostal axillary line space through a thoracoport. We'll use that to pull the diaphragm down as well, and then we'll put a chest tube in that space. And then we continue the dissection of the pulmonary artery. As you can see, we're dissecting outside of the thorax. And again, staple ligation of the ongoing PA there through that incision on the side. And then we'll just continue with the truncus branch in a similar approach through the side. But this auxiliary incision on the side, plays an important role in this operation, which I'll show you how we use the clamps afterwards. Then we take down the inferior ligament. This is all usual things, and then take the inferior vein at this point. And once the inferior vein is ligated, we then move on and take the bronchus with electrocautery and whatever remaining attachments may be. And then we deliver the lung out through that small incision. Takes a little bit of effort sometimes. Once the lung is out, then we prepare the hilum in a standard fashion. Left atrium first. Then we move on to the PA, clearing the SVC and any of the posterior attachments, getting adequate length. We then sharpen cut the bronchus back a bit. And then we start our implant. We start the implant with 2 stay sutures at the cartilaginal membranous junctions, and this allows us to bring the apex first and parachute the lung in. This takes a little bit of finessing as well. We try to go apex first, get one lobe in at a time, and the lung will go in even through these small incisions. Plops in, and then you have to do a little manipulation and make sure you have it anatomically oriented. Then we begin with the bronchial anastomosis. We do a running continuous anastomosis with PDS suture, and then we cover the anastomosis with a little bit of peribronchial tissue over the top to cover essentially cover the knot separated from the PA. We then clamp the left atrium, do left atrial anastomosis, and this is where we pass this special clamp that we've had made for this procedure through that incision on the side. And then we do the left atrium in a pretty standard everting mattress fashion. And then complete with the PA anastomosis. This is another obtuse shaped clamp that we pass right through the incision to clamp the PA. And then we carry on and do that anastomosis. And then we looked at our minimally invasive technique, our first 37 patients that we did. And what we saw was a decreased length of stay and post-transplant, ICU length of stay as well. And then we looked at FEV1 and FVC at discharge. This is out to 3 months. There's improvements up to 3 months. We're currently looking at the data. We've done 100 of these now with this technique. And we'll see what 6 month and 1 year data looks like. I bet you it'll stabilize out, but there was improvements at 3 months. And then what we saw here was that opioid prescription on discharge was significantly better in the minimally invasive group, almost half of what we saw in the traditional group. And the same with the morphine milligram equivalents provided on discharge. So opioid use was less in our minimally invasive group. And then we went further and decided to undertake robotic lung transplantation after we got familiar with this technique with the help of one of our colleagues who's a robotic mitral valve surgeon. And he made this low fidelity system here out of gloves. It's actually a bike tire, where we practiced right before we went undertaking this. To see, we're sewing the bike tube here, and that was mimicking our bronchus. And then we went ahead in January of 2022 and did the first right single robotic lung transplant. We set it up similar to the way we set up our robotic mitral cases. And you can see here the visualization is just excellent. And this allows for, I think, ease of teaching fellows and residents who really can't. It's very difficult to see through the small incision when we're doing the minimally invasive technique. We don't always have a VATS camera in place when we do that technique. And it's very difficult for, a second assistant or even your assistant to see what you're doing. So we've used the robot now in 9 cases, including bilaterals, emphysema patients, and fibrotic patients. So we're going to push the technology even further as we move forward. And this was our first case in January 2022. He did very well. He was discharged home on post-op day 11. He was a 68-year-old gentleman with emphysema. And this is his incision at follow-up. See, these incisions are roughly 6 to 8 centimeters in length. And, seeing these patients subjectively, they have less pain, even in the early post-operative period. But we're going to follow this out further and study this and see what really pain scores look like long-term on these patients. And in summary, I think, we don't think about pain control all the time, and it's paramount to early and long-term outcomes in all of surgery. It's multimodal, it's multidisciplinary. And I think that minimally invasive lung transplant is not the end-all be-all, but it may help improve this pain and pulmonary function in the peri-transplant period. And the robotic platform also has potential to even help the surgeon with ergonomics, teachability of the procedure while promoting this minimally invasive platform. But I think, in order to compare what's really going to help pain control after, whether it's a thoracotomy, whether it's minimally invasive, whether it's clamshells or sternotomies, we really need more trials evaluating different and comparing these modalities. Until then, it's very, there's not one way to do this. And I thank everyone for their attention and the opportunity to present here.
Dominic, that was wonderful. Very very impressive work. So I have a ton of questions. I'm sure others do as well. It's 1:59, but I think I'll use the chair's prerogative here to extend this to 10 minutes. So we'll continue to go for another 10 minutes. And those of you who have to leave, of course, thank you for attending. Please send any feedback to Juliet or myself. For those of you who can stay here, please feel free to put some questions in the chat box. Or, we're a close enough knit group. We're all friends here. We can even just have a live discussion. So before we move on, let me just introduce Dr. Alexander Bernhardt. He's the Director of Heart Transplantation and Circulatory Support at the University Heart and Vascular Center in Hamburg. And as you know, he's a section editor of the JHLT. Ferris Khalil was planning to also be a panel discussant for today, but I understand that he was trapped on a flight, so I don't see him in attendance here. But let me just start off with a question, seeing none in the chat box right now. So for Dr. Jeevanandam, that is amazingly impressive. My first question was just how? You went over your steps very carefully. I just had two questions. The first one is, you didn't mention acute normal volemic hemodilution. And in some of the larger aorta cases, for example, we were able to associate that with decreased blood transfusion. Do you think there's a role for ANH with your JW patients?
All right. Can you hear me?
Clearly.
Great. Yeah, actually, on my slides, we do talk about it. I don't call it normothermic preservation. We just talk about it as hemodilution. So
Right.
There's a picture there of my cardiopulmonary bypass circuit. So we actually save blood before it hits the venous reservoir, before it goes through the oxygenator. So I completely agree with you. I think the best way and the only way to really preserve and give back the coagulation factors is to preserve that blood. Now, for a heart failure patient, what we do is we stop their diuretics 3 or 4 days before we think that their procedure is going to occur. And so they build up a little blood volume, and they'll come in not completely optimized, come in with a high CVP, and we use that opportunity to save their blood. Usually we can get about 1 liter off the patient, and then we give it back to them after protamine is in and there's no surgical bleeding. So you're absolutely right. That is the best you can give them for replenishment of their coagulation factors and their platelets. It's a little tricky. What we do is, when we put our cannulation stitches in, you don't want any bleeding. So we put them in steep reverse Trendelenburg to decrease their blood pressure and their CVP. We then put in the cannulas, arterial and venous. And then I'll tell anesthesia to shut off the anesthesia so the blood pressure can go up. Then we put them in steep Trendelenburg position to be able to sequester that blood. So there's a certain sequence that's done between anesthesia, myself, and perfusion. But you're absolutely right. I mean, if we don't save that blood, then coagulation can be an issue. Now, I will say that all this stuff was done without any, can we even take about no blood products? We're not even talking about cryoprecipitate. I think in the entire experience now, which is over about 180 patients, including all the other surgeries we do, we use cryo in 2 patients, and we use Kcentra in 1. And we've not had anybody go back for bleeding unexpected. We had 1 patient who we had to pack and take back for bleeding. So you're absolutely right that normothermic dilution is critical.
It's amazing to me, a reduced sternotomy single ventricle pathology that you've taken for transplantation. It's amazing. Another question for you while we're talking, how often do you get labs post-operatively? When we do JWs here at our center, I restrict all scheduled labs to just 1 ABG post-op and at 6 hours, and then nothing after that unless absolutely required.
Yep, and we agree with that. I mean, we do a ABG. They can do ABGs like in half a cc or something. These days they have so we do ABGs. We don't actually check their labs, and if they're making urine and hemodynamically stable, we don't check them unless they show a clinical evidence for it. Now, on our transplant patients, when we had to start checking TAC levels, we will check their hemoglobins, but it's all pretty consistent. The first hemoglobin on the blood gas after surgery will look reasonable. They nadir at postoperative number 3, and then they slowly start coming back, as I showed with that LVAD patient. So you just have to anticipate that. It's really interesting. All the nurses and the post-op management ICU team gets used to it. So we actually have less blood draws on our regular patients too because of that.
That's definitely. I see one last question for you there, Valen. Anita asked the question, and I think you mentioned this in your presentation as well. ECMO in these patients is a challenge. Can you comment on your experience and strategies peri-heart transplant in these JW patients with ECMO?
Yeah, that's a very good question. It is a big challenge. So we've had 3 patients in the immediately post-operative period who needed to go on ECMO for acute donor heart dysfunction. 2 of them survived, and one was that patient with the situs inversus who had an aspiration and did not. So we've run hemoglobins as low as 4 or 5 with patients on ECMO. And in one patient, we actually left them on ECMO for about 2 weeks till we got the hemoglobin up to about 7, so we can go ahead and decannulate. But and preoperative ECMO, that is a problem. 2 of our patients did have ECMO before their surgery. We like to do it via graft into the subclavian, or axillary, so it's a little bit more controlled. And both those patients were men, large men, and so you're able, they have a larger blood volume. Hemodilution is not that much of a problem when they go on cardiopulmonary bypass. We're able to get away with it. We have not done a ECMO female with a low hemoglobin yet.
That's wonderful. For anyone to hand up or add questions. Now we do have another question in the box here, and I'll read that in 1 second. Dr. Loor, I had a few questions for you. Maybe I'll just be brief and then we'll get onto the chat box here. I was really interested in the work that you did looking at inflammatory mediators. There are some companies now on the market that are marketing these filters that could adsorb various molecules. Do you feel like there might be a role in those patients that we have to go on mechanical circulatory support around lung transplant to adsorb or actually filter out these inflammatory mediators?
Yeah, I think that's a great point. The answer is almost certainly yes. I mean, there's enough data that there are key innate immune markers that we know are implicated in graft dysfunction in lungs and that are also implicated in MCS support. So it's a wonderful marriage there between that knowledge and the CytoSorb device or other. The challenge is making sure that they definitely work and are taking all of the key mediators out. I actually observed a PhD thesis defense where they compared 2 cohorts of animals, one's using CytoSorb and one's not, and there was no difference in the end, and there was some question as to whether it was truly absorbing all of it. But I think that yeah, if we can get those molecules down substantially or target them in other ways, I do think there's going to be substantial benefit in lung transplant in particular.
John, before we get on to your question there, Gabe, I actually had another question for you as well. So LVAD implants are, of course, you mentioned this, that there's a bit of a confounding bias with the longer pump times are definitely in sicker people that require additional procedures. Do you feel like there's a categorical cutoff in some, so could you say that a pump time greater than 60 minutes with a VAD has an inflection point for a poor outcome? Or do you feel like there's just so much confounding characteristics of those that require a longer pump run that it's hard to give us that sense of this number, there's an inflection point? I mean, is it linear or is it sort of a bit exponential?
So yeah, we looked at it in a single center and it was linear actually. In this Intermax registry, we removed the concomitant procedure, so it was a little bit more clear. Yeah, almost certainly ones that are longer are having some issues, right? I mean, could. But on the other hand, you know, the difference between an hour or going into that 1 to 2 hour intervals can be subtle. And we had seen it in our own experience where we started doing, you know, like putting the inflow cuff off pump and then just going on for a very short period to do the outflow, and had just anecdotally been seeing, like, you know, phenomenal kind of extubation results and ICU length of stay results. So that kind of got us down this pathway of studying this a little bit further. I don't know where the inflection point is going to be. I mean, it's a complicated procedure and we're getting more complex cases, so I think you have to use it. We'll have to look and see, you know, we'll have to look through that registry. I bet you we can find an inflection point, hopefully, for the manuscript.
Interesting.
Yeah.
Dominic, a couple of questions for you. Really impressive. Honestly, I was shocked that you were able to do lung transplant through these little kind of mini mitral size incisions. So a question in the chat box from Dr. Iskender. Very nice minimally invasive techniques, and I agree. What's it going to take to further the adoption? I mean, that's one question. What's it going to take to further adoption of minimally invasive techniques worldwide? But the question that's raised here is, it seems like sternotomy may be less painful, although more invasive. What's been your experience comparing sternotomy with all of the above, clamshells, minimally invasive approaches? Is sternotomy still a good tool in the toolbox for lung transplant?
Yeah, great question. So our practice now, last year, I think we did 3 clamshells we did 74 lung transplants last year. We did 3 clamshells, and then around almost 50% of our patients are done through minimally invasive technique. And then the rest of the patients are actually done through sternotomies now. We almost never we did a clamshell yesterday for silicosis patients. So if we have a redo, if we have silicosis, bronchiectasis, someone we know is going to have significant adhesions and need a lot of adhesiolysis, we'll do a clamshell. But we've been very successful in adopting sternotomies. We've even done a handful of completely off-pump sternotomy bilateral cases. Usually the left side's difficult to do with a sternotomy. You got to go on ECMO to really manipulate the heart. But we've been able to do a good handful, over 5 now, completely off-pump with sternotomy. And absolutely, you know, we haven't studied this, but I can tell you, just seeing the patients, and we know from cardiac surgery, the sternotomy is not that terribly painful of an incision afterwards. You compare that to a thoracotomy, even the mini thoracotomies may be more painful than sternotomy. So I think sternotomy is a great option. I know a lot of people have gotten away from it in lung transplant, and clamshell is great. You know, you could teach through clamshells, a lot of great exposure with a clamshell, but we've had, you know, just having a few disaster cases where clamshells have fallen apart, big infections of that space. We've just gotten away from it. And I'll be honest, it's not fun to close at the end either, that clamshell. So you put all these factors in place, and I think to answer the other question too, adopting a minimally invasive approach, it is difficult. You have to be patient to do it. My partner, Pedro Caterino, came from, you know, the UK, where he was doing it for about 5 years out there, and he had a similar sort of, you know, buy-in. Some people liked it, and as soon as he left, he said, yeah, they're probably not doing it anymore. So we started doing it here, and then we just started pushing the envelope, making the incisions even smaller, and then carrying that to, you know, the robotic platform. So I think there is utility in it. It just takes time, and it's teachable. We've had 5 fellows now since we started doing it that we've trained, and I can tell you 3 of them can do it in practice. It's not easy to start. You really got to be facile and patient with the longer instruments. But once you start doing that, I think it's just taking it step by step. And I think there may be more people who will take up robotic, you know, especially thoracic surgeons that are very familiar with the robot, and putting that as their platform for minimally invasive. So I think there's a lot of utility for it. Will it change PGD outcomes, long-term mortality? Highly doubt it. But I think one of the key things is really the patient's perspective on their lung transplant is like, wow, I had a lung transplant through this. You know, it's really remarkable the way they come looking. in the clinic post-operatively. So I think the psychological aspect of it, the pain control aspect of it afterwards, and maybe the pulmonary function, we'll see. We're looking to look at our data. We have 100 patients now that we've used it on. We've only studied the first, 37 at 3 months, but we're going to have 6-month and year-long data to look at soon. So I think it's promising, but it's not something that everyone, anytime I talk to colleagues about doing it, they say, that's not the problem with lung transplant, the incision. We have so many other issues to deal with first, which is probably true, but I think it's one part of the big puzzle.
That's wonderful. Okay. Are there any other questions or comments from any of the participants, speakers, or panelists?
I mean,
I
I may
oh.
just add some. I mean, it's fantastic what we heard, but it came into my mind that this is all these 3 talks came from centers very experienced with a lot of a great team using robotics to do lung transplants. Some of the participants here in the audience may come from centers that don't do that much minimally invasive stuff and robotics, and maybe coming from countries without all these options. We should keep in mind it's really great to have such leaders in the field to see what is possible, but we should keep in mind that this is. It can be the standard, but it isn't in the world, and it's okay that it isn't the world, but it's good to see what is possible.
Wonderful. I agreed. Well, with that, thank you very much, everybody, for joining us. This was great. Thank you to our speakers. Those were great talks. You guys truly are masters in the field. This is wonderful. And I look forward to our next meeting.